Yes, I'm really excited to be here and to share the stage with those who are actually putting this work into action. So I'm very much looking forward to the presentations to come. I really want to give a thanks to Lancet Oncology for the incredible support that they gave us through the writing of this commission, which took several years. And as you can see, it really took a village of people to produce. We were led by Carlos Rodriguez Galindo and Rafat Atun and my co-vice chair, Sumit Gupta, and these other 40 people. So it really took a village to produce. I want to say that it's 47 pages long, and I hope you do download it to read it. It's freely accessible, thanks to Lancet. And I'll put this link into the chat after I'm done speaking, because there's a lot more detail there than we'll have a chance to discuss in the next 10 minutes. So I think what we were trying to counter with this commission was the narrative, the false narrative about treating childhood cancer in low and middle income countries, specifically that it was unaffordable, unattainable, and inappropriate. Unaffordable meaning costing too much, unattainable, impossible to do, inappropriate because it shunted resources from children with more prevalent or diseases. To tackle this problem, we divided the work up into 4 main categories. First of all, what is the current burden of disease globally in terms of incidence and survival? What is the true cost of treating childhood cancer? How do we scale up a treatment? And what would be the return on investment if we could cure children with cancer? What would society get back? This was where we started. This was the truth as we knew it going into the commission at the time, which were the incidence data produced by the institute by IARC, published in their latest volume of the incidence of childhood cancer. And what they show from the cancer registry data that did exist was that there was very wide variability in the age standardized incidence of childhood cancer. For instance, here, even in Asia, you can see that the estimates range from 79 per million children to 163 per million children in just within Asia itself. And the question is, why? Is that truth? And so what we did was to take the data that existed and model what the true incidence of childhood cancer is. And I think one of the key things that we took into consideration is what were the percentage of children who were going undiagnosed? How real, how true was cancer registry data? From the model that we built, which unfortunately I don't have time to go into, but is part of our report, we estimated, yes, that there are approximately 232,000 children who are diagnosed in the world, which was consistent with other estimates produced by IARC, produced by the Global Burden of Disease, validating in a sense the underlying assumptions in our model. But what we showed was that 181,000 children in the world were undiagnosed, so that the true incidence of childhood cancer is closer to 413,000. And you can see here that varies, of course, dramatically by income status. And so in low and middle income countries, the percentage of children who are going undiagnosed is more than half. And so I think that really explains to a large extent that wide variation in incidence that had often been cited. We also looked at the survival of childhood cancer in a separate model. And as you can see here too, given the data that does exist from studies such as the Concord study, there's also a wide variability in current survival of childhood cancer. And we, just to summarize this data that you can see here that's displayed by a heat map where red is the lowest survival and green the highest, we also documented huge disparities in survival currently in low-income countries where the survival on average is 5%, 50% in middle-income countries, and 80% in high-income countries. And I think this gives a little bit more nuance to the statement that is often made that survival of children in low-income countries is 20%. I think it's actually lower on a population level, not at high performing centers in low income countries, but across the entire population. So with this in mind, with the model, we projected forward to 2050 over the next 30 years, and we said, what would happen if nothing changed? And this graph is incidence projecting from 2020 to 2050. And this graph is the number of deaths. And what I want to show you is that the burden is only going to grow due to population growth in low income and low middle income countries in terms of incidence. And actually it's going to go down in upper middle income countries where birth rates are going down and essentially stay the same in high income countries. And what that translates to also, obviously, is that the burden of death is going to grow in lower income countries if we do nothing at all as well. So that by 2050, 84% of the deaths in the world will be in low and middle income countries. We next really delved into how do we scale up treatment in low and middle income countries. And through the work by Avi Denberg and Paula Friedrich and Catherine Lamb, there's a large section of the commission that really looks at this issue in detail. We were fortunate to have collaborators in India, Philippines, Guatemala, El Salvador, Ghana, who really provided beautiful case studies of places where the gains in survival have been dramatic over recent decades. We also spent time really talking about what needs to have ready to really take on childhood cancer care, including national cancer plans, cancer registration, public data sets, and then at the hospital level, what are the capabilities and packages of services in detail needed at each level of care? And this is just one figure from that section produced by Paula Friedrich that really shows that one of the things we really need to start talking about is networked care, shared care across a regional network. And I think we'll hear more about how that's already been put into place already in several countries in Asia. But then the next step that we took was to really try to model what the effect would be. So in the same incidence and survival models that I showed you, what would the effect be if we could scale up care? What's possible? And to do that, we did that under the construct of what we called the care cascade, and breaking it down into the various steps at which maximal achievable survival is not possible because of either limited access to treatment or major socioeconomic factors, or the quality of care that can be delivered, which gets to issues around effective infection control, a wonderful supportive social work department and nursing staff that's competent at recognizing turns in the clinical state of the patient and can activate help as quickly as possible, things like that. So using this conceptual model where we looked at the possible scale up of each one of these components, we then estimated what would be possible from 2020 to 2050 in terms of the annual number of deaths. And this line here is the baseline, and these are the three different sort of buckets of intervention that one could put into place: treatment, access or referral, or attention to socio-demographic issues such as abandonment. And you can see that each one individually can decrease the annual numbers of deaths globally by themselves. But what was very interesting, I think really is one of the most important messages from the Commission, is that it really takes a combination of all three things implemented at once to really see dramatic change, a really dramatic drop in the number of deaths. And what that really means is that increasing survival for children requires strengthening the entire health system. It's not enough to get the drugs. It's not enough to have, a surgical suite with a qualified surgeon ready to go. It's not enough to have a social worker who's making sure that no child abandons cancer. It's really the combination of all of those things that will have a dramatic impact on childhood cancer survival. We next turn to cost, and in 3 centers in Ghana, El Salvador, and Mexico, the teams there allowed the team of Dr. Gupta, Dr. Denberg, and Dr. Horton to really look in detail at what it cost to operate the center versus what the survival was in that center over the same period of time. And the bottom line here is that it's actually quite inexpensive by cost-effective standards to treat childhood cancer, so that in Ghana, the cost was $1,034 per disability adjusted life years, El Salvador, 1,624, and in Mexico, 3,039 DALI. And just to put that into context, what is a cost-effective threshold that we think is worth in putting forward a new treatment? For instance, in the United States, there are various levels of what is thought to be cost-effective, but to put forward a new drug, it's thought that it should be at least less than $100,000 per DALI. You can see we're just several orders of magnitude below that in terms of what it really costs to treat childhood cancer. So again, then taking that data on cost, we then plug that back into the model and asked if we could cure children, if children went on to live a full adult life, and we did adjust for the impact of treatment and the shortening of life of our childhood cancer survivors that we see and the associated medical conditions that they have to deal with. So we did incorporate that into the model. But even still, when you return a child to health and allow them to become a functioning adult, they then have the opportunity to bring economic productivity to society. And again, I think one of the important things that we showed in the commission was that for every dollar that we invest in treating a child with cancer, we cure enough children that on average $3 are brought back to society in terms of adult productivity. So in terms of return on investment, this is a very, very strong case for treating childhood cancer. Now you can see that this does vary a bit by income level. And again, this is mostly driven by the expected life expectancy of adults in those countries. But you can see that even in low-income countries at this point, that these boxes are low, the cost is low, the productivity is low, but the net benefit is still positive, even in the lowest income countries. So going back to the false narrative, unaffordable, unattainable, inappropriate, I would say that we've answered no to all of those questions, that the cost per life year saved is quite low, the return on investment is high, that treatment is attainable, that there's already high quality and effective care that we documented being delivered in low and middle income countries, and that what we really need is more sustained financing in the form of universal health care and inclusion of childhood cancer in essential packages, as well as focused research on healthcare delivery in the most effective way to build up cancer care. And is it inappropriate? And again, I think the answer is quite strongly no, because I think what we showed is that to improve childhood cancer survival requires that we strengthen the entire health system, which of course will have benefits for all children, regardless of the underlying diagnosis. So again, I just want to thank my co-authors on this project, and especially again, Lancet Oncology for their very wise and stewardship of this work. I will hand this back over to my collaborators. This is a infographic that Lancet Oncology has produced that perhaps if we have more time, we can come back to later. But I want to finish to hear about the work that is actually going on. So thank you very much.